هنتكلم على introduction cardiovascular system. introduction to cardiovascular system راح نسوي refreshment لمعلوماتنا القديمة about anatomy, physiology, and some of the most important presenting symptom in cardiovascular disease. As we know, anatomically, the heart, the cardiovascular system involving the heart and the vessel. And the heart is located in the thoracic cavity, midline and a little bit to the left side of the chest. It comprises less than 50% of the transverse thoracic dimension. And the heart is conical in shape with its base directed to the left side, apex, and the base is behind the sternum, between the third and fifth rib. The heart has four surfaces. We have the base of the heart, we have the apex, anterior wall, and this is the posterior wall of the heart. And regarding the chambers of the heart, we all know that the heart acts as a two separated units, the right side and the left side, and each one of these units consists of atrium and ventricle. So we have the right atrium, right ventricle, left atrium, and left ventricle. This is the anatomy of the heart from the anterior surface of the heart. This is the right atrium, which receives blood from the venous blood from superior vena cava and inferior vena cava, ejecting this blood through tricuspid valve to the right ventricle. And from the right ventricle, blood will be ejected through the main pulmonary artery into the lung, oxygenated there, go back through pulmonary veins into left atrium, and then left ventricle, and then to the aorta, and distributed all over the body. This is the shape of the functional unit of the heart. As we mentioned, this is the right atrium. This is the right ventricle. In between them, there is the mitral valve, separate between them. And this is the right atrium, right ventricle, and this is the tricuspid valve, and this is pulmonary and aortic valves. About the layer of the heart wall, it consists of three layers. The most outer layer is the epicardium. The thick muscular layer is the myocardium, and the inner layer is the endocardium. All this is covered by the pericardium, which is regarded as the coverage, أو يسمى شغاف القلب, which is the coverage of the heart, covering the heart and the great vessels. Regarding the pericardium, it is a sac, consists of two layers, the visceral and parietal layer, the serous layer, and it encloses the heart and contains some fluid. The function of this pericardium that it protects the heart from injury, protect the heart from infection, and it contains some fluid that allow lubrication for the movement of the heart. The usual amount of fluid is around 50 ml of fluid present in this sac, and this is the pericardial fluid. The epicardium is regarded as the most outer layer of the heart, and it consists of the visceral layer of the pericardium. The more important is the myocardium. It is the thick muscular part composed of individual cardiac muscle called as cardiomyocyte. They join together by intercalated disc, and in cases of bicollagen and other substances forming the extracellular matrix. This is the functional unit of the cardiomyocyte. The myocardial fibers consist of actin unit and myosin unit, and the myosin unit consists of the troponin complex, tropomyosin, and the myosin body. The action potential is initiated in the conductive system of the heart, and it conducted through this myocardium from one myocardium, cardiomyocyte, sorry, to the another myocyte. The most important point here is that there is a difference between the cardiomyocyte and other muscle like skeletal muscle. The main difference that the cardiomyocyte have what is called as refractory period, which means when there is an action potential activating the cardiomyocyte will take its time for the contraction and for repolarization. During this period, if there is any other external action potential or stimulation to the myocardium will not respond to this stimulation, and this period is called as the refractory period. This characteristic of cardiomyocyte prevents what is called as tetany, which can be occur in the skeletal muscle. The skeletal muscle respond to any stimulation, but the cardiomyocyte have an important period called the refractory period. During this period, it will not respond to any contraction, and this is called the refractory period. The endocardial layer is the inner layer that lining the heart and the great vessels. Regarding the valve of the heart, we have 4 valves separating the 4 chambers of the heart. We have 2 valves separating artery from ventricles, which is the mitral valve and the tricuspid valve. And we have 2 valves separating ventricles from great vessels, the aortic valve and the pulmonary valve. The mitral valve consists of 2 cusps, 2 leaflets, and this separates left atrium from left ventricle. These valves respond to change in pressure gradient across the valve. For example, when the left atrium is filled with blood, the pressure in the left atrium will be higher than the pressure in the left ventricle, so this valve will open, allowing the blood to pass from left atrium down to the left ventricle. Then, when the pressure in the left atrium decreases, the valve will be closed, preventing any blood to go back from left ventricle to the left atrium, and so on for the other valves. The tricuspid valve normally consists from 3 leaflets. This is the aortic valve, usually consists of 3 cusps and 3 leaflets, and also the pulmonary valve consists of 3 cusps. The valve apparatus, it's not only the leaflet. This is the valve apparatus. This is the mitral valve. It have the valve ring, which is a fibrous ring, fix the valve at its position between the atrium and ventricle, and to this ring contacts 2 leaflets, the anterior leaflet and posterior leaflet, which is the part أو خلينا نقول عليها هي بوابات الفالف اللي تتحرك, which is movable part of the valve, and it allow for opening and the closure of the valve. The tip of this leaflet is attached to thready structures called as chordae tendineae, and this chordae tendineae attached to the wall of the ventricle by papillary muscle. Any disease in any part of this can lead to valve damage or valve destruction or valve dysfunction, whether it is due to ring dysfunction, due to leaflet dysfunction, chordae tendineae dysfunction, or even papillary muscle dysfunction. The great vessels that attach to the heart, we have the 2 great vessels. So we have the aorta and the pulmonary artery. The aorta taking blood from the left ventricle. This is the aorta taking the oxygenated blood from left ventricle, pass it through the aorta, and it is distributed to all parts of the body. And the pulmonary artery, which taking blood from the deoxygenated blood from the right ventricle and take it divided into main left and main right pulmonary artery to left and right lung for oxygenation. If we are talking about the coronary circulation are the coronary arteries, which are the arteries that supplying the myocardium of the heart with its blood supply and its oxygen requirement. We have two main coronary arteries. They originating from the ascending aorta, from the aortic cusp. We have the left coronary artery and right coronary artery. The right coronary artery usually
دكتور عفوا المقاطعة، بس يعني الصوت كلش ناصي، يعني يا دوب أتصل الكلمات وشوي زي يقطع.
اوكي، هسه الصوت أقرب، هسه أفضل.
والله دكتور حلو ناصي.
ليش ناصي دكتور والله؟
شو المشكلة؟ زين، ممثل الجروب، اقدر ادز لك الملف وانت تسوي شير وانا احكي معكم من الموبايل؟
نعم دكتور عادي، ممكن تعمل شير من
هذا يسوي شير
يعني
ما يسوي
من الموبايل، ممكن
ما يسوي شير من الموبايل. I don't know why.
دكتور احنا كنا سمحنا للشير بس تدوس شير سكرين وتاخذ الملف من الموبايل.
ما يسوي شير اني باوربوينت فايل.
ما مشكله دكتور عادي.
شير الشاشه يطلع حتى كل الشاشه.
I know بس من عاد احاول اسوي شير الفايل
باوربوينت
ما يسمح لي.
ما مشكله دكتور، ابعث لي هو هسه شير.
هسه دزيت لك هو انت على الخاص. اذا انت تشير اعتقد وصلك حتى نحول.
نعم وصل. نعم دكتور.
اذا انا راح افتح هسه على شو اسمه، وانت الشير راح يكون يمك، راح نوقف.
تمام.
اوكي
تمام دكتور.
We have two coronary arteries. We have the left coronary artery and the right coronary artery. The right coronary artery supplying the inferior wall of the heart. And in the left coronary artery, on the left side, which is called as the left main coronary artery, it will be divided into left anterior descending artery, which the left anterior descending artery will supply most of the anterior wall of the heart, and the left circumflex, which supplying the lateral wall of the heart. Next, please. If we go back to the physiology of the heart, we have what's called as cardiac output, which is the amount of blood ejected by heart in each minute. And the cardiac output is equal to stroke volume multiplied by heart rate. The stroke volume is the amount of blood ejected in each beat. في كل beat, if we multiply it by the number of beats per minute, this is the cardiac output. If we look to this equation, whenever there is an increase in stroke volume, there will be an increase in cardiac output. And whenever there is an increase in the heart rate, there will be an increase in the stroke, in the cardiac output, but this for some extent. In resting condition, the cardiac output is around 5 liters per minute. Next, please. Next, Mustafa, yes. The stroke volume is the regulation of yes. The stroke volume is regulated by three important factors: the preload, afterload, and myocardial contractility. Next, please. The preload is the stretching of the cardiac muscle prior to contraction, and this stretching depends on the amount of blood in the ventricle at the end of diastole. As we know, the cardiac cycle is consist of systole, which is the contraction of the myocardium, and diastole, which is the relaxation of the ventricles. At the end of diastole, the amount of blood, this will produce stretching in the wall of the ventricles, and this is called as the preload. Whenever there is increased preload, there will be increase in stroke volume and then increase in the cardiac output. In some conditions, وهي راح نستفاد منها مرة راح نتكلم على الارثمية. In some conditions, when the heart rate reaching 160 beat per minute or more, أكثر من 160 beat per minute, the heart will contracting very rapidly. There will be no time for the ventricles to be filled with blood. So the end diastolic volume will be low, the preload will be low, and this will decrease in cardiac output. ولهذا عندنا قسم من المرضى اللي يجونا with tachyarrhythmia, with their heart rate more than 160 beat per minute, they may present it with severe hypotension because there is no time for the ventricles to be filled with blood. Next, please. The myocardial contractility, it is the strength of contraction of the myocardium. The more cardiac contractility, the more cardiac stroke volume and more cardiac output. And this myocardial contractility is dependent on the sympathetic and parasympathetic system activation. When there is an increased sympathetic activity, there will be an increased myocardial contractility. And when there is decreased sympathetic activity, there will be decrease in myocardial contractility. Also, it is affected by drugs. Some of the drugs, which is called as positive inotropic agents, may increase myocardial contractility and increase cardiac output. And we can use these drugs for patients with low cardiac output or in patient with hypotension, like digoxin, like dopamine. It can be given and it will increase contractility and then increase cardiac output. The others, negative inotropic agents, which have negative effect on the myocardial contractility, can decrease the myocardial contractility. And also these can be used like beta blocker or calcium channel blockers. We can use them in some condition when we need to decrease myocardial contractility, like in patient with ischemic heart disease and in patient with high blood pressure. Next, please. The afterload, the other factor is the afterload. And the afterload is the pressure that must be over the pressure in the great vessels that must be overcome by the ventricles to be to produce valve opening. And whenever, it means that peripheral resistance to the blood, whenever the afterload increase, there will be decrease in the stroke volume and decrease in cardiac output. هون العلاقة صارت علاقة عكسية مو مثل البريلود والمyocardial contractility. A good example of an increased afterload is hypertension, systemic hypertension. Systemic hypertension will increase the pressure in the aorta. وهذا increase pressure in the aorta احنا تكلمنا انه الفالف opening يعتمد على البريشر gradient between the two chambers. فاحنا اذا كان عندنا البريشر بالفنتريكل اعلى من البريشر بالايورتا, الفالف will be open normally and all blood will be ejected. لكن من يكون البريشر in the aorta مساوي للبريشر in the left ventricle, فهذا ما راح يسمح لنا proper opening of the aortic valve, وبالتالي راح يقل عندنا الستروك فوليوم. Next, please. The heart is affected and the nerve supply of the heart is under the supply by the autonomic nervous system. We have the sympathetic and parasympathetic activation. The main receptor present in the heart is beta-1 receptor, and activation of beta-1 receptor leading to increase in the heart rate and increase myocardial contractility. Inhibition of beta-1 receptors leading to decrease contractility and decreasing heart rate. Other receptor present in the cardiovascular system is the beta-2 receptor, which is present mainly in blood vessel, not in the heart. And activation of beta-2 will allow vasodilatation of the vessel. In the heart, mainly we have beta-1. That's why when we want to use drugs to inhibit this receptor and decrease myocardial contractility, we should use the drugs that better to use the drugs that are cardioselective, مثل cardioselective beta blocker, which inhibit beta 1 only and not affecting blood vessel or affecting the bronchi. The sympathetic system activation will release norepinephrine, and this norepinephrine, its effect on heart will increase the heart rate, increase myocardial contractility. Next, please. Activation of parasympathetic system on the opposite side by vagus nerve, and it will release acetylcholine, and its effect will be reduction in heart rate and reduction in myocardial contractility, and it is regarded the predominant supply for the heart, usually during resting condition. Next. The conductive system of the heart, it is a specialized myocardium. Its function is to initiate and propagate the action potential and electrical activity of the heart. The conductive system of the heart consists of the sinus nodes, which are present in the top of the right atrium, between the junction of right atrium and the superior vena cava. This is regarded the pacemaker of the heart. This is regarded the pacemaker of the heart, and it gives a heart rate variable between 60 to 100 in the usual condition. It is under effect of sympathetic and parasympathetic system. When there is activation of sympathetic system, the sinus node will increase its firing, causing increase in heart rate. When there is activation of parasympathetic, there will be inhibition of the sinus node, and there will be the reduction in its firing and reduction of heart rate. From the sinus node, the action potential will be transmitted to all parts of atrium, right atrium and left atrium, and this will cause contraction of the atrium. Then the action potential collected into the AV node, and from the AV node, it will go down to activate the ventricles, left ventricle and right ventricle by left bundle and right bundle. Next, please. The result of this activation of conductive system will be apparent on ECG by this wave. The P wave represents the atrial contraction. When the atrium contracted on ECG, we will see this as a P wave, the initial wave, which is an up wave. Then the contraction of the ventricles or depolarization of the ventricles will be apparent as a QRS complex, and the repolarization, the relaxation of the ventricle will be apparent as a T wave on ECG. Next. If we come to the examination and auscultation of the cardiac sound, as we all know, we have first heart sound and second heart sound, which are the normal sound. And if we put a stethoscope, انتم اخذتم هذا الشيء يمكن بالclinical sessions, we will hear first heart sound as a loop, second heart sound is a dup, loop, dup, loop, dup, and it will be repeated. The first heart sound represents the sound produced by closure of the mitral and the tricuspid valve. The second heart sound produced by closure of the pulmonary and aortic valve. The duration or the period between first heart sound and second heart sound is the systole, and between second heart sound and the next first heart sound is the diastole. Sometimes we have an extra sound like S3 and S4. S3, it is due to rapid ventricular filling, and this may be physiological in adolescent, in a pregnancy, in thyrotoxic patient, or it may be pathological like in patient with mitral regurg. And we have the S4, fourth heart sound. It is due to atrial systole, and almost always it is pathological like in patient with hypertension, severe hypertension, or patient with hypertrophic obstructive cardiomyopathy. Next, please. Now we are previous, please. Yes. Now we will talk shortly about the presenting problem to the in cardiovascular system, the main manifestations and symptom of patient with cardiovascular. Next, please. The main problem that the patient with cardiovascular disease is presented with is the chest pain, shortness of breath, palpitation, syncope, leg edema, and other symptoms. If we start with chest pain, before starting with chest pain, there is one classification which is called as next, please, Mustafa. Next, yes, is the New York Heart Association. This is a well-known classification, universal classification. It will assess the functional condition of the patient. وهذا classification متعارف عليه عالميا. يعني أنت من تريد توصف مريض with cardiac disease وتقول أنه this patient is NIHA class 3, we will have idea about the condition of the patient. The class 1, when the patient having no limitation during ordinary activity. يعني البيشنت يقول لك I have chest pain, I have shortness of breath, but this not interfere with my ordinary activity. يعني أنا أروح للشغل أشتغل بس من أسوي severe exercise أو moderate to severe exercise بيصير عندي this chest tightness or shortness of breath or chest pain. يعني مثلا تعريف المودريت أنه walking for more than 500 meter. أما إذا أقل يقول لك I am well. The class 2, slight limitation during ordinary activity. Shortness of breath or chest tightness while performing mild to moderate exercise, like getting up one stairs يصعد طابق واحد أو walking for about 200 meter. يقول لك من أعمل هاي الأعمال يصير عندي shortness of breath. هذا نعتبره نيها class 2. The class 3, marked limitation of normal activity without symptom at rest. يعني the patient told you that I have shortness of breath while I am doing my usual daily activity. مثلا يقول لك إذا أقوم أصلي وأرجع يصير عندي shortness of breath. إذا أطب للتواليت وأطلع يصير عندي shortness of breath. I cannot change my clothes alone. I develop shortness of breath. هذا نسميه نيها class 3. هذا النيها احنا ان شاء الله نرجع ندرس الكلينيكال راح نستعمل هذا الكلاسيفيكيشن بكثره. نيها class 4, the patient who have dyspnea or shortness of breath at rest. يقول لك دكتور انا قاعد انا حيصير عندي symptom. This is called as نيها class 4. Next please. Starting with chest pain, chest pain انتم راح تاخذوه يعني حاله حال any pain in a clinical session, how to assess any pain regarding site, radiation, onset, aggravating factor, relieving factor, associated symptoms, whatever. لكن هون إذا نتكلم على most common causes of chest pain. Chest pain may be due to anxiety, may be due to cardiac conditions like myocardial ischemia, myocardial infarction, pericarditis, mitral valve prolapse. كل واحدة بها خاصية معينة. من راح ناخذ الموضوع راح نتكلم على خواص الchest pain وشون نفرق هذا الchest pain هو ischemia, MI, pericarditis إلى آخره. Aorta may be due to aortic disease like aortic dissection or aortic aneurysm. It may be due to esophageal disease like esophagitis or esophageal spasm or Mallory-Weiss syndrome. It may be due to lung disease like bronchospasm, pulmonary infarction, pneumonia, pneumothorax, tracheitis, pulmonary embolism, malignancy. Musculoskeletal diseases كل واحدة بها خاصية معينة. osteoarthritis, rib fracture. المسكولوسكيليتال عادة يكون very localized pain. يعني البيشنت يوصف لك نقطة معينة أنه pain in this point and associated with localized tenderness. إذا تضغط على هاي المكانات البيشنت he will feeling pain. هذه ميزة المسكولوسكيليتال. It may be due to neurological conditions like disco prolapse, herpes zoster, or thoracic outlet syndrome. Next, please. If we going to differentiate between ischemic and non-ischemic or non-cardiac chest pain. In location, the ischemic chest pain on the left side it is central or diffuse. بهذا الصورة اللي on the left side of the slide. بالمقابل ال non-cardiac pain may be peripheral or it may be localized to one point. Talking about the radiation, the ischemic cardiac chest pain may radiate to the jaw, radiate to the neck, shoulder, arm, and sometimes to the back, while the non-cardiac pain may be radiated to the other part, or it have no radiation, only localized pain. Regarding the character, the ischemic chest pain, this is a very important point. The patient feeling ischemic chest pain has a chest tightness or squeezing or choking. يعني يقول لك البيشنت something compressing my chest or heaviness on my chest or something choking. شفتي يخنقني. Non-cardiac or non-ischemic pain, it may be sharp, stabbing, catching, pricking, burning. أي مريض يجينا with this pain عادة هو non-cardiac pain. يعني المريض اللي يقول لك أحس نغزات بصدري, this is non-ischemic pain. patient اللي يقول لك I have كأنما stabbing, كأنما سكين ده تدخل بصدري, this is not ischemic pain. The precipitating factor, ischemic chest pain is usually precipitated by exertion or by emotion, while that pain is maybe spontaneous or not related or no specific precipitating factor. Relieving factor, the ischemic pain is relieved by rest and by nitrates, while the non-ischemic pain usually is not relieved by rest and it may be more prolonged pain. Ischemic pain may be associated with shortness of breath, sweating, while that of non-cardiac pain may be associated with other respiratory, gastrointestinal, or locomotor manifestations. Next, please. This is the characteristic description of a patient. يعني احنا عندنا كثير مرضى يعني من يقف ينطينا الهيستوري he develops some movement of his hand like this person يعني يعمل الفيست of his hand on his أو pressure مثل هاي الصورة اللي جوا.
تسمعني؟ الو
وصل يمكن.
Yes. اوكي.
نعم دكتور.
نعم. فيعمل حركة بإيده مثل هاي الصورة اللي on the right بالوسط. يعصر إيده هالشكل ويخليها على الchest. كأنما دا يوصف his chest pain is constricting like this pain. Next please. Next مصطفى تسمعني؟ Yes.
نعم دكتور أسمعك.
Yes. The other manifestation of cardiovascular disease is the shortness of breath. Shortness of breath that patient, it may be acute or chronic, and we have a long list of causes of shortness of breath. Some of it due to cardiac disease, some of them are due to respiratory disease, some of them may be due to systemic diseases. Cardiac, it may be due to acute pulmonary edema, respiratory acute shortness of breath may be due to acute severe asthma, acute exacerbation of COPD, pneumothorax, pneumonia, pulmonary embolism, and so on. And also it may be due to systemic like metabolic acidosis, ketoacidosis, hyperventilation, like psychological upset or others. Next, please. هاي في كل disease راح ناخذه وراح نتكلم على التفاصيل. احنا اليوم بدنا نمشي شوية بسرعة حتى نحاول نعوض النقص اللي صار عندنا. Now we are talking shortly about some of the investigations that we may need and use in cardiovascular diseases. Next, please. The most important investigation, which is easy, available, cheap, is the ECG, Electrocardiogram. It is the machine that records through the chest wall the electrical activity of the heart. يعني الهارت normally مثل ما شفنا بالconductive system صورة الconductive system اكو فد electrical activity بالهارت تنتقل من مكان إلى مكان حتى تحفز الcontraction of the heart. هذه electrical activity احنا ممكن نسجلها through the skin of the patient by connecting electrode on the skin on the chest wall of the patient وتطلع عندنا as a paragraph recorded on a paper. هذا الريكورد نسميه electrocardiogram. Next, please. طبعا ال ECG it is a very important investigation. It is used for diagnosis of many cardiac condition and many non-cardiac condition، مو فقط للكاردياك كونديشن. بهذه المحاضرة أنا ما راح أغطي كل المانيفستيشن اوف اي سي جي لأنه يعني يحتاج لمحاضرات طويلة جدا، بس احنا راح ناخذ البيسكس هسه. وبكل ديزيز ما راح نتكلم على كل ديزيز، راح نتكلم على الاي سي جي فايندينج اوف ذات ديزيز.
سوري دكتور.
اوكي خلص الوقت يمكن.
لا دكتور موجود عادي بس ثواني.
نعم، فاحنا بالاي سي جي راح راح نتكلم يعني احنا هسه مثلا انا راح اعطيكم البيسكس اوف اي سي جي، الويف اوف اي سي جي، لكن انا ما اقدر اغطي كل البوينتس اباوت اي سي جي. هذه البوينت راح نغطيها من نجي على each disease specifically. يعني انا من راح نجي على الارثميا راح نعرف كل فيتشر اوف اي سي جي، وانتم collectively تجمعون الداتا. It can be used for diagnosis of the different type of arrhythmia, for diagnosis of myocardial ischemia and myocardial infarction, pericarditis, chamber hypertrophy إذا كان عندنا left ventricular hypertrophy, right ventricular hypertrophy and so on. It can be used for assessment of electrolyte disturbances يعني hyperkalemia, hypokalemia, hypercalcemia, hypocalcemia. All of these may produce some ECG changes, and also it can be used for diagnosis of some can give a clue about diagnosis of some of drug toxicity like digoxin and others. Next. الاي سي جي بيبر اللي يسجل عليها الباراجراف هي الورق البياني الاعتيادي. وبالورق البياني انت مثل ما تعرفون اكو سمول سكوير اللي هي 1 ملم، واكو لارج سكوير اللي هي 5 ملم. الهوريزونتال لاين يعني مصطفى ما اعرف اذا تقدر تستعمل بوينت لان انت الهوست. اذا الهوريزونتال لاين الخط العرضي،
لا والله دكتور.
اوكي الخط العرضي مال البيبر يمثل لنا الديوريشن، يعني يمثل لنا تايم. كل مربع كبير مثل ما مؤشر عندكم جوا بالخط الاحمر، كل مربع كبير اللي يحتوي على 5 مربعات صغار يساوي 0.2 سكند. فكل مربع صغير بالتالي هو 0.044 سكند. هذه راح تفيدنا بايش؟ احنا ليش ناخذ هاي التفاصيل؟ تفيدنا انه من نحسب الديوريشن اوف ايتش ويف. يعني انا مثلا اقول لك احسب لي هذا الكيو ار اس كومبلكس هو نارو لو وايد كيو ار اس كومبلكس، فنحسب الكيو ار اس كومبلكس ماخذ كم مربع. يعني لو افترضنا الكيو ار اس كومبلكس ماخذ مربعين صغار، المربع الواحد 0.04، فبالتالي راح يطلع الكيو ار اس كومبلكس ويت 0.0 سكند. 0.0 سكند يس. فهذه تفيدنا بهالحساب الويف، وهو لانه اكو diseases associated with wide wave. الخط العمودي الفيرتيكال لاين يمثل الفولتج of the electrical activity. ايش قد كميه الكهرباء اللي احنا عطسنا من الهارت، كميه الفولتج اللي عطسنا it will be presented on the vertical line. كل ما تكون الفولتج اكثر كل ما يكون الvertical length of the cardiac wave is higher. المربع الكبير الواحد اللي هو 5 ملم يساوي 5 ملي فولت. Next please. طبعا هذه ممكن تزيد وممكن تقل in some diseases. الاي سي جي الاعتيادي الحقيقه هو يتكون من 12 ليد، 6 ليد لمب ليد و6 هما chest ليد. طريقة ربط الليدات مثل ما واضح عندكم بالصورة، احنا نربط 4 wires on the lead. عادة الرايت ليج هي راح تكون الإيرث والبقية الليمب ليد راح يشتغلون، ونربط 6 wires 6 lead on the chest wall in the 4th intercostal space on the right, 4th in the left، بعدين 5th intercostal space to the left, anterior mid clavicular, anterior axillary and mid axillary line. اختاروا هذا العدد من الليدات حتى يغطي، لأن هذا العدد من الليدات هو يغطي تقريبا all surfaces of the heart. يعني يغطي لنا الانفيريور سيرفيس، يغطي الانتيريور سيرفيس of the heart واللاترال سيرفيس of the heart. هذا هو اليوجوال ليد اليوجوال ليدز اوف اي سي جي. من يجيك يوجوال اي سي جي راح تشوف فيها هاي 12 ليد. الاكو سم تايمز احنا نحتاج الى اكسترا ليد. يعني انت مثلا تتوقع انه البيشنت هافينج بروبلم ان ذا رايت فنتركل، ممكن نستعمل الرايت سايد الاي سي جي. الجست ليد مكان ما نخليها الليفت انتركوستال سبيس راح نخليها بالعكس، نعكسها نخليها on the right side of the chest. اكو sometimes نحتاج ان نصور البوستيريور wall of the heart، فممكن ناخذ الجست ليد ونخليها behind on the back of the patient below the scapula ونسميها C7 C8 and C9. This is an extra, this is not the usual. نحتاجها في حالات معينة، لكن اليوجوال وهذا ال 12 lead of the ECG. Next please. الاكشن بوتنشال مثل ما قلنا احنا يبدي عندنا اول شيء هو atrial contraction، والatrial contraction will be presented as a P wave. Then after that there will be contractions of the ventricle. اول جزء contracted in the ventricle هو الانترفنتريكولار septum. بعدين يصير عندنا activation of the left ventricle and the right ventricle. الشكل اللي راح يطلع هو QRS. Next. الليدات هي متوزعة وكل ليد يراقب جزء معين من الهارت وول. يعني مثلا ليد 2 اللي هي مؤشرة باللون الأزرق ومكتوب عليها inferior. ليد 2 ليد 3 and AVF. These leads watching and recording the inferior surface of the heart. هذا الفيجر نفسه راح نستعمله وراح نتكلم على myocardial infarction. These lead monitoring the inferior wall of the heart. احنا بنصير عندنا changes بالinferior MI راح نشوفها in these leads. البينك in color هي اللاترال اللي هي lead 1 AVL V5 and V6. V1 and V2 اللي هي red هي السبتال تراقبنا الانترفنتريكولار septum. V3 and V4 تراقب الانتيريور wall. فهذا هو الديستريبيوشن of the leads. Next please. الشكل النهائي لل ECG اللي راح يطلع هو like this. The first wave هي ال P wave اللي هي ال up wave. بعد عندنا ال PR segment أو PR interval خط عدل. بعد تظهر عندنا Q wave اللي هي down wave. R wave اللي هي up wave and S اللي هي down wave. مو بكل الليدات راح تظهر عندنا هالشكل هذا. يعني عندنا قسم ليد ممكن نشوف small Q tall R، وبقسم ليد ممكن نشوف small R deep S. هذا يعتمد على مكان الليد بالجست وشنو الالكتريكال اكتيفيتي اللي اتصلوا. Next. Start with the P wave. شنو الابنورماليتيز؟ ال P wave it represent atrial contraction and the P wave is usually up wave. Abnormalities اللي ممكن نشوفها بال P wave انه ال P wave may be absent like in patient with atrial fibrillation. It may have abnormal configuration wide P like in patient with left atrial dilatation أو تكون tall P like in patient with right atrial dilatation. بكل وحده من هاي الديزيزز اللي تكلمنا عليها من راح نيجي ناخذها سيبريتلي راح نشوف عليها اكزامبلز واذا ندخل بتفاصيل. Next please. الاذر سيجمنت اللي يجي بعد البي، هذا الخط اللي بعد البي هو نسميه البي ار انترفال. النورمال بي ار انترفال is 0.12 الى 0.2 سكند، يعني من 3 مربعات صغار الى 5 مربعات صغار. الابنورماليتيز اللي ممكن نشوفها بالبي ار انترفال انه ممكن يكون شورت اقصر من الطبيعي like in patient with WPW syndrome. فالسيندروم راح ناخذه بعدين لما نتكلم عن الارثميه. or it may be more prolonged like in patient with heart block. ايضا راح نتكلم بكل تفاصيله بعدين ما راح نتكلم عن الارثميه. next please. ال QRS complex it represents the ventricular depolarization. Normally ال QRS complex duration is 0.8 to 0.12 second، يعني من مربعين صغار إلى 3 مربعات صغار. It may be too long, it may be too wide حسب ال diseases of the ventricles. Next please. نمشي شوية سريع حتى نحاول نغطي المحاضرة بالوقت المطلوب. بعد ال the QRS complex, you have the ST segment, and this ST segment may be elevated or may be depressed below the line. وهذه راح ناخذ بكل تفاصيل لما راح نتكلم على الاسكيميا والventricular hypertrophy والى اخره. Next please مصطفى. next please. next.
دكتور جس فصل يوم النت.
اوكي خلينا نتكلم عن الاس تي سيجمنت على ما يصلنا. الاس تي سيجمنت it may be elevated or may be depressed، يعني ممكن يكون above the isoelectric line or it may be below the isoelectric line. عادة the most common cause of this abnormalities in ST segment هو ischemic heart disease، وراح ناخذ الاسكيميا راح نتكلم بكل هذه التفاصيل. Differential diagnosis of ST segment elevation, it may be due to acute coronary syndrome, left ventricular aneurysm, Prinzmetal angina, pericarditis, early repolarization syndrome, and left bundle branch block, or what is called some syndrome called as Brugada syndrome. مصطفى انطيني next slides اذا انت معنا.
الو
اي نعم معنا رجعت.
نعم دكتور. نعم
next please.
تمام دكتور بس ثواني.
اوكي
ايوه هنا وصلنا دكتور.
هسه الشيرنج ستوبت، انا ما يظهر عندي اي شيء.
ثواني. شير سكرين ستارت. ثواني دكتور هسه راح يطلع.
اوكي
تمام. تمام دكتور. ST segment.
next اللي بعده.
next نعم.
The next wave in the ECG is the T wave, which is usually up wave, and it represents ventricular repolarization. The abnormalities اللي ممكن نشوفها بال T wave, whether it is present or flat، هي راح تصير مثلا tinted أطول من الطبيعي in patient with hyperkalemia، أو تكون flat in patient with hypokalemia. Next please. T inversion أيضا ممكن يصير عندنا بالإسكيميك هارت ديزيز. أنا ما أعرف الألوان يمكن أوضح يمي من يمي لو لا، بس يعني شوي الألوان يمي شوي confusing. We have what's called as a QT interval، اللي هي الفترة ما بين بداية الكيو إلى نهاية التي، هذا كله نسميه ملون لون وردي يسمى الكيوتي interval، normally 0.36 إلى 0.4 second. هذا ممكن يصير ب prolongation in patient with ischemic heart disease, in patient some medications in like anti-malarial agents مثل hydroxychloroquine. الضجة اللي ظهرت على hydroxychloroquine من استعملونه بالكوفيد 19 في بداية استعماله أنه it causing sudden death، أنه سببه أنه هو يسوي prolongation of this QT interval، وممكن هذا الprolongation يؤدي إلى ventricular tachycardia و ventricular fibrillation. أيضا it may be due to ischemia, may be due to hypocalcemia وإلى آخره. Next please. This is a patient with long QT. إذا نحسب الديوريشن ما بين الكيو ويف ونهاية التي ويف it will be too long، فهذا it may leading to arrhythmia. Next please. Another investigation and easy and available are the cardiac biomarker. These biomarkers are certain material that tested in peripheral blood and indicate some cardiac diseases. من ضمنها البرين natriuretic peptide. The natriuretic peptide, it is a substances, proteins excreted from the left atrium in response to increased left atrial pressure. يعني الهارت من يتحسس انه البريشر بالليفت اتريوم is high like what occur in patient with heart failure، راح يفرز هاي الماتيريال. هاي الماتيريال تشتغل كدايوريتيك افكت، تحفز انه يصير عندنا يقلل البريشر in the heart. ف if we detect this material, if we have a patient, two patients presented with severe shortness of breath and we cannot differentiate whether this shortness of breath is due to heart failure or COPD. نفحص this material. إذا طلعت high this is due to heart failure. إذا طلعت normal فمعناته أنه this is due to short COPD. إيش قد بقى لنا من الوقت؟ 5 minutes وبعدين يدخل دكتور خلدون.
نعم دكتور.
نحاول نكمل إن شاء الله. The other material is the cardiac. لا sorry please. cardiac troponin اللي هي certain protein مثل ما أخذناها present in the actin unit of the myocardium, and it can be detected in the peripheral blood when there is myocardial necrosis. So it can be a marker of myocardial necrosis. Next please. The other test is the exercise test, ECG. It used to detect myocardial ischemia. When we're having a patient with features suggestive of myocardial ischemia, while the resting ECG is normal, we can use this exercise. Next, please. Next, Mustafa.
نعم دكتور.
Yes, this is the exercise ECG.
هنا دكتور.
Yes, here. This is أول ECG هو ECG during rest. The patient having normal ST segment. بالexercise صار some ST segment depression. This means that there is ischemic heart disease. احنا كبسنا محاضرتين ومحاضرة واحدة فشوية سريعين حتى نعوض النقص اللي صار عندنا بالأسبوعين الماضيين. The other test is the Holter monitor, ambulatory. هذا الهولتر مونيتور عبارة عن ECG يسجل for 24 hour. راح نتكلم عليه بتفاصيله من راح نتكلم عن الأرثمية. يفيدنا في تشخيص حالات الأرثمية that it is transient. يعني يجي البيشنت يقول لك دكتور I have arrhythmia short lasting، كل ما أسوي ECG يطلع نورمال. وممكن we can connect the patient on this device يسجل 24 hour إلى حد 1 week ECG ونقدر نقرأ بالحاسبة الأرثمية اللي صارت during this period. Next please. The chest X-ray also can be used for detecting many cardiac diseases and differentiate between cardiac and pulmonary diseases, assess cardiac size, pulmonary edema, and so on. Next. Next, please. Next, please. خلينا نعبر هذا الموضوع. ننزل إلى الإيكوكارديوغرافي. We have two types of echocardiography. It is an ultrasound technique. It is very useful technique, available, easy, non-invasive. Then we have transthoracic echo, assessing the chambers of the heart, the valve of the heart, and we have transesophageal echo, putting the probe of echocardiography in the esophagus, usually used to visualize the left atrium and mitral valve. Next, please. This is the echo device. Next, please. Next. And this is the echo view. All cardiac chambers will be apparent by this. We can assess dimension. We can assess valve abnormality. We can assess contractility. Next, please. Next, please, Mustafa. Yes, this is another view of the echocardiography. We can assess contractility, and we have equation which is called يعني إذا تشوفون هاي الأرقام آخر رقم 61.3% اللي هو EF ejection fraction. The ejection fraction gives us an idea about the left ventricular function. Normal ejection fraction above 50. الرقم above 50 نعتبره normal. If it is below that, this indicates that the patient having LV dysfunction. This number can be calculated easily by echocardiography. Next, please. عبر لنا هالسلايدين الثلاثة اللي قادمين هانتم تقدرون تطلعون عليهم. Next please. بس حتى نكمل الموضوع. We have also computed tomography CT scan of the heart and the great vessels sometimes can be useful in investigation, and also we can visualizing the coronary arteries by CT coronary angio. Next. Next MRI also. We have the coronary cardiac catheterization. هذه invasive investigation can use assessing chambers of the heart, pressure in the chambers of the heart, and visualization of the coronary circulation. Next, please. This is the coronary angiography, injecting a contrast material in the coronaries and using an X-ray projection We will visualize the details of the coronary artery. Any stenosis, any obstruction can be easily evident on this investigation. Next, please. And electrophysiological study, it produce intracardiac ECG. It can be diagnostic and therapeutic. راح نتكلم بتفاصيل لما راح نتكلم على الارثميا. خلصت المحاضرة. ما أعرف إذا عندكم أي question. We have 2-3 minutes. هي كانت بس refreshment وintroduction للمواضيع اللي راح نتكلم عليها بالمحاضرات القادمة.
ECG يعني نحن ما نعرف نقرانه يعني.
ECG مطلوب طبعا. ECG مطلوب. ECG يعني أنا قلت اليوم تعرف في لي الويف، البي ويف ماذا تعني، الQRS ماذا يعني، الST سيجمنت ماذا يعني، وهكذا. من أجي أتكلم على الإسكيميا راح أشرح لك كل الECG فايندينج بالإسكيميا. راح أجي أتكلم على الأرثميا راح أحكي كل الECG فايندينج بالأرثميا، وهكذا. أنا ما أقدر أغطيها كلها هسه بسيشن بهالمحاضرة. أوكي؟ فيعني هو مطلوب. نعم
دكتور، نحن نعرف نقرأ يعني نعرف نحدد إذا أكو مثلا وايدر أو نارو، بس يعني أقصد من غير فيو مثلا، غير فيوات مثلا بوستيرير ولا هذول ما نعرف نقراهم. يعني مطلوب إنه
كله مطلوبة، كل ما نصل إلى الديزيز اللي نحتاج بينه هذا الموضوع اللي ذكرتينه راح نذكر تفاصيل. أوكي
دكتور، ذكرت على الكونتراست ما فهمت وشلون يعني ايش راح ندخله حتى يغشعنا كوروناري ارتري.
هذا كاثيتر. اذا نرجع الى الصوره شويه مصطفى جوبا. انا ما اعرف دكتور خلدون معنا على الخط، انا اعتذر شويه اخذت من وقته، بس لا العفو.
خالف على راحتك.
اعتذر دكتور لان احنا صارت عندنا مرتين عطله يوم خميس فشويه تاخرنا.
صحيح.
هذا دكتور
يس ذس فيو. هذه فيو اذا تشوفون بالتيب اوف ذا ليفت سايد اكو فد كاثيتر. هذا كاثيتر ندخله ثرو ذا ارتريال سيستم الى الاسندنج ايورتا ونسوي بيه كانيوليشن بالليفت كوروناري ارتري. ندفع كونتراست ماتيريال وفي نفس الوقت ندوس اكس راي، فراح تطلع الصوره الكوروناري فيسلز راح تطلع بهالشكل. راح نشوف عليها صور وفيديوهات من نتكلم على الاسكيميا.
نعم دكتور.
يس. اكو other question؟ اوكي شكرا جزيلا جميعا. هاي المحاضره
شكرا دكتور.
بعد. شكرا دكتور خلدون واعتذر على الاطاله.
دكتور على عيني. سالي بسيطه موفق ان شاء الله.
شكرا استاذ.
شكرا دكتور.